Good morning, everybody. I'm Elaine Harkins. I'm the ADRC director here at Legacy Link. I want to welcome you guys to another, ACAP Hall County presentation. So this morning we are going to hear from Dr. Vanessa Schaeffer about recognizing and managing anxiety and depression in older adults.
Good morning. Can you all hear me without a microphone? Good. It's coming from Chicago, so I can get my voice next door if I need to. Welcome to this presentation sponsored by ACAP through the UNG Institute for Healthy Aging and Legacy Link, which I think is such a great combo of resources. There's my friend Philippa. Good morning. I'm going to talk with you today about recognizing and managing. Have to use it. Can't hear me.
It's kind of hard to hear.
Okay. I'm sorry. Did not mean to fail to do that. Okay. This morning we're going to talk about recognizing the signs and technical symptoms for a diagnosis of either depression or anxiety in an older adult. And then we're going to talk about what you do to get mental health care. In the United States, only 3% of older adults receive mental health care from an actual mental health professional. That's a real problem. By 2030, there will be more people over 65 than under 18, so we are really going to need people who specialize in the care in every aspect of their lives of older adults. You don't send an older adult to a pediatrician, and you don't send your child to a geriatrician. The problem is we have a ton of pediatricians and not so many geriatricians. So we'll talk about how to look for the right kind of professional. And we're going to start, I'm going to tell you a little bit about myself. I'm a clinical geropsychologist. I've been practicing for almost 30 years. The beginning of my career focused on all ages of people, but in the past 3 and 4 years, I have focused exclusively on retraining in working in geriatrics, and I see people over 65 for short-term therapy, and I provide consultation nationally with families who are looking for help negotiating challenges with their older adults, both physically and emotionally, and it's the best job ever. Let's start with anxiety. We're going to talk about some of the facts, some of the statistics. What is it? Does anybody here know anybody who has anxiety? A couple of people. Okay. It's defined as excessive worry and nervousness that causes distress or interferes with daily activities. Pretty broad description. Please know if you learn one thing today, getting anxiety, having a diagnosable anxiety disorder is not a normal function of aging. It's not typical because you're old, you're going to be anxious. That's also true about depression, okay? It's highly treatable. Mental health interventions for anxiety are incredibly successful, and it's highly treatable in older adults as well. Okay, we're going to talk about all of the breakdowns. These are the 5 most frequently diagnosed anxiety disorders in an older adult, and I'll go through them individually with you. But they are agoraphobia, panic disorder, generalized anxiety disorder, specific phobias, and social anxiety disorder. Okay? The first one is agoraphobia. It's the fear of being in situations where you think you might not be able to get yourself out of the situation. You think you can't escape from it, you won't be able to get out of the room, or you think something might happen to you that would be embarrassing. If you have issues with mobility, falling, if you have issues of incontinence, you might not be able to find or utilize a restroom. There are some people who have agoraphobia don't want to be anywhere but where they're most comfortable, typically in their home, and sometimes people can't go to certain places. So using public transportation is very difficult. Being in wide open spaces, being in closed spaces, covered parking lots are a popular complaint I hear about when people have these symptoms. Being on a train, a bus, standing in a long line, going to any event where there's more than just a few people, and particularly if they're strangers. So what's important is that the fear the person feels is out of proportion to the actual risk that exists, okay? For clinical diagnosis, the symptoms need to last more than 6 months, and we need to see that they're causing problems in the person's day-to-day functioning abilities, okay? Panic disorder. Experiencing recurrent unexpected panic attacks is the key of this disorder, and a panic attack is an unexpected surge of anxiety or fear, during which time 4 or more of the following symptoms are present for the person: heart pounding, heart racing, rapid heart rate, sweating, becoming trembly, feeling as if you're somebody standing on your chest, feeling lightheaded, faint, dizzy, feeling like you're choking or you can't swallow, hot flashes, chills, GI complaints, feeling like you need to go to the bathroom over and over, fear of losing control, fear of dying. It's the disorder that sends the most people to the emergency department. People go and they say, I'm having a heart attack. I'm sure I'm having a heart attack. They do a whole workup. Nope, your heart's in great shape. Come back again next week, same thing. It's a way that I get a ton of referrals from ER docs who say this is an anxiety disorder. Generalized anxiety disorder is kind of our catch-all, but it has to do with excessive worry, interfering with your daily activities, and worry that is not soothed or calmed by a caregiver or a loved one saying, you're okay, you're safe, I'm here, nothing will happen. The worry is persistent and it's debilitating for people. That worry, those symptoms are associated with feeling restless, feeling keyed up or on edge, being very easily fatigued, more so than normally, difficulty concentrating or feeling that your mind is going blank, feeling like you're not really present in the moment, muscle tension, and sleep disturbance. You always want to watch your older adult for changes in their sleep habits. That indicates something, sometimes physical, sometimes mental health. Specific phobias, everybody knows there's tons of movies about phobias, right? An intense, irrational fear of a place or thing or event that poses no or little threat to a person. One of the reasons it's really important to have an older adult evaluated by a mental health professional is you might think what the person's phobia or fear is about is not a reasonable thing, but you need to know a person's entire history, right? You need to know if they've been exposed early in their life to trauma, or they've had some sort of incident that would cause a recurrence of an anxiety or a depressive disorder. So sometimes people will say, I'm afraid of spiders. And then I will find out that at some point in their life they had a bite from something I never heard of before I moved here, a brown recluse spider. And then they have these photos of their body part that I'm like, okay, can't look. And that would make you afraid of spiders, right? So there's times that things really get us on the path, and there's times that we're afraid of things that we're never exposed to. Fear of flying, fear of driving on the highway, being in closed spaces. Lastly, social anxiety disorder. I think this is personally the most profound one, because anything that contributes to an older adult isolating or having less social interaction diminishes the quality of their life very quickly. I personally believe, and professionally, that the quality of our life is most closely correlated to the quality of our relationships. And disorders that make us have trouble interacting with other people, we have to address right away with our older adults. Social anxiety disorder, when an individual feels overwhelmingly anxious and self-conscious in everyday social situations, things they used to be able to do with really no problem, all of a sudden not. They describe an intense and persistent fear of being judged by other people, being evaluated negatively, and they also have fears about being judged because of a physical appearance change that might have to do with an impairment or disability. People, when they start using a cane or a walker or a wheelchair, not going to church in my wheelchair, I'll have to sit in the middle of the pew and everybody will note I'm not going. So, the disorder causes people to feel embarrassed about perceived or real deficits, somebody who is in early onset dementia, who is social, notices that they're having some trouble remembering a name or recalling a circumstance, and so they get quiet, they get withdrawn. Physical symptoms when a person is in a social situation can include things like blushing, getting red blotches, heavy sweating, trembling, nausea, and difficulty forming sentences. All right. The reason it's important to know the signs and the symptoms is because the sooner an older adult is identified as having anxiety and later depression, the sooner intervention happens, the more quickly and the better the treatment goes. And the better the treatment goes, the less chance of another episode later. Okay? So it matters that you're here learning this. Some of the signs, those were the symptoms that I gave you, but these are some of the signs you might notice in your person. Excessive worry or fear from somebody who wasn't really, a terrible fretter before. Refusing to do daily activities that they used to participate in. Being physically restless, pacing. A lot of times if people are pacing, we see that in dementia as well, so it's important that we discern what's what. Racing heart, shallow breathing, trembling, nausea, sweating. People will lose their appetite. They will want to stay in bed. They will seem very avoidant. You'll see changes in their sleep habits. You'll see them describing muscle tension or feeling weak or shaky. Sometimes people who ambulate fine will be grabbing things to walk around. They're perceiving that something could happen to them physically or otherwise. If asked, they'll describe significant concerns about their safety, even in the absence of increased risk, and they'll avoid social situations. How common is it? We think that about 1 to 15% of people over 65 meet the actual diagnostic criteria for an anxiety disorder, but a study, as you see here in 2011 from the Journal of Geriatric Psychiatry found more than 27%, close to 30% of older adults reported significant symptoms, enough so they don't make the diagnosis, but their life is being impacted by what they're feeling. All right, what causes it? What are some of the things? Does it sometimes come with no cause at all? Sure, sometimes people say to me, I'm anxious and nothing is going wrong. And I say, all right, well, we're going to work from there. And sometimes people say, I have had this chronic medical condition for so long, and it's every day, it's something new. There's a new symptom, there's something else coming. I'm just waiting. I feel a sense of dread. Sometimes people are taking a new medication, and medication interactions or side effects can cause people to have many of the symptoms. Physical limitations in daily activities. The more somebody's independence is challenged, the greater their chance for becoming anxious, because life is really unfamiliar now. I always knew I could jump up and get in the car and drive somewhere. I always knew I could fill in the blank. And now I'm needing more help with that. And what if I never stop needing help? What if I can't ever do anything for myself again? What am I going to do? Sleep disturbance. Sleep is so critical at every age, really important. Other issues, substance abuse, the death of a loved one, loss, change in social status, change in financial status. In older adults, anxiety and depression occur often together. That's not always true with younger cohorts. And when they do occur together, the symptoms are more severe, typically. Excuse me. What happens if we don't treat it? What happens if we say, oh my gosh, my hands are full, I'm doing everything I can, I'll just tell her that nothing's wrong and she'll be fine? You have a greater chance with an untreated mental health disorder to develop a dementia disorder. Depression is both a precursor of and a consequence of dementia, right? So in the majority of people diagnosed with dementia disorders, the first observable symptom is a change in their mood. And often we think, well, you're getting older. Of course you're not going to, your friend just died, you're whatever. But one of the reasons we have to be really careful to look at this is to see if something else, this deserves treatment, but what if something else is developing? Early intervention for every condition is better for people of all ages, but especially older adults. They report overall poorer physical health, increased disability and impairment, and a diminished quality of life. The best treatment. The first thing you do with your person that you love is you get them to their primary care physician, okay? Even people say to me, well, we just got out of the hospital. And I say, well, you went to the hospital because there was a fall and you were evaluated for all the things related to the fall. But maybe they didn't do all the blood work that we'd want to see. We want to see if there's a B12 deficiency. We want to see how your blood sugar is, even if you're not diabetic. You're going to go to your primary care physician and you're going to take a list of the symptoms and the signs and the concerns, and you're going to say, we don't know if anything's wrong, but we want to make sure. Could these be related to anything else? A lot of times physicians will catch these medicines shouldn't go together, or this would be a better choice, or the timing of the dosage is causing some side effects. So anxiety is treatable in older adults. The earlier the condition is identified and addressed, the easier to reverse the symptoms. The first step, primary care. The gold standard of treatment for older adults with anxiety is a combination of talk therapy, counseling therapy, psychotherapy we call it, and pharmacotherapy, which is medication specific to anxiety disorders. I'm going to give you a little pitch for something that's challenging, especially in Hall County. People, as they age, metabolize medicine differently, all substances differently, and it's critical that the person who's diagnosing and prescribing for them understands how medications affect an older brain and understands what medicines you should never use with an older adult. And so to the extent which you have the chance to see a geriatrician, I think we have 2 in Hall County, maybe 3, and they're full. On any week I could fill their practice. To the extent you can get somebody that is experienced and you say to them, we're paying careful attention about the medicines we're using in my 80-year-old mother, right? We want to make sure we know. The load to an aging brain of medications that are fine in a 50 or 40 or 60-year-old is different than how certain medicines affect our cognitive reserve. And cognitive reserve has to do with how healthy our brain stays and how diminished our chances are, therefore, for developing a dementia or other cognitive disorder. So, talk therapy. I help people to understand how they're thinking about things. I can't change what's happening, but we can talk about what you're telling yourself is happening for you. And we can talk about your relationship patterns. I can take a look at whether people have adequate social support or not. A lot of times not. And we can make changes, behavioral changes, for optimizing their health. No matter what area they're starting out of wellness and health, there's always something we can do to improve things a little bit. So, cognitive therapy, cognitive behavioral therapy, is an evidence-based form of treatment in older adults for anxiety. And that's important because your mental health practitioner should only be using research-backed strategies for interventions with your loved one. Okay, medication. Medication may have an important role. It may not be necessary for everybody. It may not be usable. Most anti-anxiety medicines are short-term, right? And so if people have a chronic, pervasive all day long, we don't want to medicate somebody every 3 or 4 hours just to keep them. We want to use some other interventions. And really good physicians know that there are other medicines, some of the antidepressants, that work really well on symptoms of anxiety. So you want ideally to take your loved one to a psychiatrist who knows geriatrics. There are a few. I have one psychiatrist that I work with who unfortunately does not take Medicare, but is willing to do a 1 or 2 time evaluation with somebody to render their opinion of what would be good, and then their primary care or a local doctor will follow that protocol, which is the best workaround I've been able to find so far until we raise some more good psychiatrists working with older adults. Okay, we're going to switch to depression. which is defined as a mood disorder that causes persistent feelings of sadness and a loss of interest. We also call it clinical depression or major depressive disorder, and it affects how people think and feel and behave, and it can lead to a variety of emotional and physical problems. The individual may have trouble doing day-to-day activities, and they may not always express this, but they may begin to feel that life is not worth living. The highest rate of successful death by suicide are among white men 85 years of age and older. That is this population we're talking about. Also, when we combine, 1 in 2 veterans is now an older adult. 1 out of 2 veterans is over 65. And when we couple things like PTSD, other trauma, whether PTSD has been diagnosed or not, and we have the challenges that can come with aging, these are things we really want to pay attention to. This is why. Okay, how common is it? It's interestingly, clinical depression is less common in people over 65 than it is in adults, right? So younger adults compared to older adults. It's less common, but it's equally treatable. It occurs at the following rates. 1 to 5% of people living in community, meaning in their own homes or with people of their choice, right? Friends or family. 10 to 12% of older adults who are in the hospital, 13.5% of people who require home health care, especially if that's a new change for them, and 14 to 42% of residents living in long-term care communities. That's almost half, right? So if you are caring for an adult who all of a sudden has been in the hospital, has been just released from the hospital, is having a prolonged stay inpatient, or is having home health care that they didn't, you really want to assess, you really want to ask questions. I'm talking about what do you see in your daily interactions with your loved one, but now I'm telling you that when certain events happen for people, you need to get curious and ask, even if the person isn't volunteering that they're distressed and you're not seeing symptoms. If we know there's things that make people vulnerable, we want to check those things out. Okay? Signs of depression: persistent sadness, tearful, people who aren't usually weepy or tearful, people describing feeling worthless, helpless, hopeless, comments like, what's the difference? Doesn't matter anyways, I don't care. Excessive worries. Older adults tend to worry about finances because they hope their money lasts as long as their life. That's not abnormal, but I'm talking about persistent fretting. We can't soothe them, you can't reassure them. Restlessness, pacing and fidgeting, or the opposite, being unusually still. People will say, she looked like a courthouse statue. She just stood so still. She's not mobile and fluid and limber. Difficulty concentrating, I'd add making decisions, problem solving. People who are pretty decisive usually, who can come up with their answer or their opinion, being uncomfortable in doing so, or seeming that they're struggling, figuring something out. Physical symptoms that are not related to any other diagnosis of a medical condition. GI complaints, pain that they haven't had before. If people meet 2 or more of these symptoms, feeling slowed down, weight changes due to changes in appetite, not due to a medicine they might be taking, changes in their sleep, too much or too little, and here's the big one again, withdrawal from social contacts, interactions. If they meet 2 or more, that makes us think we have to get a formal evaluation for the person. What causes depression? As we age, we often experience changes in our health and our circumstances, our lifestyle. It is ageist to think nothing good comes of aging, but it is silly not to say certain things really do change, and we need to be ready for those things and make adjustments, and we need to adapt the best we can. But we also need to notice when a person is feeling very lost after a new factor comes into play in their lives. More than half of major depression among people 65 and older has never been diagnosed previously. It's diagnosed for the first time as an older adult, and this is called late onset depression. Other risk factors: the presence of a newly diagnosed physical disorder or a chronic disorder that's getting exhausting to manage. Patients who have recently experienced a stroke, bypass surgery, or hip fracture. In my internship, one of my jobs was exclusively to run a support group for people who had had open heart surgery, and I think the group was 25, was a very large group. It was more educational than interactive. I think there were 25 people, and 24 of them were diagnosed with major depression, and that was the case throughout my entire year of running that group with different people. Having a hip fracture, poor health, physical or functional disability, and sensory impairment. When you can't hear as well as you used to, and when you can't see as well as you used to or at all, you are not interacting as much. And now we're back to my social interactions, my significant others, my ability to hear what's going on and see what's going on, both in terms of keeping myself safe and in terms of like, is my best friend sitting here? I want to have a conversation with her, and here I can't find my hearing aid, I've lost it, or I've never gone to get one because I have nobody to take me. Severe and chronic pain, really, really hard to manage. Stressful life events, childhood life events, trauma earlier on. People can have a recurrence of a major depressive disorder years after the first one was diagnosed. So, again, other risk factors, prior episodes of family history, cognitive impairment, at-risk drinking, use of alcohol in an abusive way, or illicit substance abuse, misuse or abuse of prescription medicine, and that includes, to me, when people are not taking prescribed medicine. It's not just taking too much or taking it at the wrong time. It's there's really something I'm supposed to be taking and I'm not, and the consequences of that physical illness not getting ameliorated at all is causing me to feel hopeless. Income changes, retirement, financial difficulties, and living alone. I said depression is a precursor and a byproduct of dementia. Untreated depression increases an individual's vulnerability to develop a dementia disorder. That is kind of a no-brainer, right? Like, address it, treat it, offer relief from those symptoms, and now we've taken one of the risk factors for dementia off the table. Depression often goes untreated in older adults. The number one reason for this is ageism, internalized ageism, and ageism coming from caregivers and family members and healthcare and even mental health. I have people say to me, I do not want to work with old people. It takes them forever to tell their story. And I say, well, their story's really long. So if you just want short stories, you should see children who just sit there and tell you fantasy, because they didn't live through any of that. And physicians who say, oh my gosh, I'm supposed to see a person in a 15-minute primary care visit, and I can't get through the first two problems, and they want to talk about everything that hurts. You know, there's a famous story in geriatrics where an 87-year-old man goes to the doctor. He was an avid race walker, and he developed knee pain, and he goes to his doctor, and he says, here's how my knee feels, and I can't do what I'm doing. The doctor, with a straight face, looks at him and says, you know, your knee's 80 plus years old. What do you expect? And he says, yeah, but my other knee is the same age and it feels great. So, same thing. Like, there is not an older adult on the planet who does not deserve care and attention and intervention until the last day of their life with the same courtesy and interest and compassion as every other age. So people say, you know, all her friends have died and she can't drive. Of course she's depressed. Here, Ma, do this. That's not paying attention, right? It's not normal. It's not a normal function of aging to become depressed. Say that to yourselves now, because you will reduce your own ageism internalized by anticipating your own aging process as not being fraught with only mental health disorders and physical disabilities, right? If you say, I'm going to notice how I'm feeling and I'm going to get treatment for it, and I'm going to engage in healthy, positive behaviors that reduce my vulnerability for anxiety and depression, you're going to be great when you get old. You're going to be in great shape. Another thing that is an issue with this population is stigma and negative beliefs around what it means to need mental health care. You know, we don't air our dirty laundry, we don't tell people our problems, don't share your business with other people. The idea that depression is shameful, or it's a lack of effort, or a moral weakness. And it's important as a loved one to not say to your person, anything that's shaming about it. You want to use, we'll talk about how to talk with them, but you want to use compassion and care and curiosity and not blame or shame or, oh, you really seem like you're in a bad mood all the time. Not helpful. Okay, what happens if depression goes untreated? A lot of the same things as with anxiety: diminished quality of life, increased use of the healthcare system. People whose mental health disorders are treated in older adulthood have fewer visits to healthcare system overall, privately, and to hospitals, to larger agencies, increased disability and impairment, and a higher risk of suicide. According to the National Council on Aging, untreated mental health problems, including substance abuse, are associated with poor health outcomes, including increased complexity of the course and prognosis of many regular medical problems, increased caregiver stress, and increased mortality. All right, what are the treatments? Number one, we take them to our way to go. Exactly. We say the same thing. We have a list. We don't just say, she seems off. We say, you know what? She's eating half as much as she used to. She's not getting up like she used to, or she's not sleeping. I'm hearing her wander around, or she's tearful, or she's pacing. You want to take the goods with you. You tell them what you already know, and then we'll help you piece together what you might not be seeing. Okay, so that's number one. Number two, talk therapy. And older adults say, well, my daughter wanted me to talk to you, but I just don't want you to think I'm a complainer. And I say, this is not complaining. You have to tell me what you feel not okay about. And then we're going to talk about how you're thinking about it, how you're coping with it. Are you coping with it? Do you have the coping skills for this problem? You have a problem at age 70. You've lived 70 years and you've never had that problem, and you think you're supposed to know what to do about it? Now, maybe you can extrapolate some of your earlier problem-solving skills, but what if they don't apply? Like, some of my work is really just, here's the problem, what are some things we could try with it? Some of it is talking about your feelings, but a lot of it is talking about what you tell yourself about your feelings and what you're really doing every day. If you're physically able, when's the last time you moved your body? Walking from the bed to the bathroom to the kitchen, not called exercise, right? What are you doing? Studies have shown that engaging in a well-researched psychotherapy is a critical part of recovering and preventing a depression relapse, okay? There are several kinds of evidence-based talk therapies for treating depression. Cognitive behavioral therapy, sorry, I went ahead, my apologies. Cognitive behavioral therapy, reminiscence therapy, where we talk with an older adult about their past. I talk with them both about terrible times to remind them they've already survived that, and wonderful times to remember that it didn't always feel like this to be alive, and a little bit of both. And people like to tell their stories. Also problem solving, there's all kinds, and interpersonal therapy, where we use the therapy relationship to model positive ways to interact in relationships with other people. Caregiving is really, really stressful, and it can quickly diminish the quality of a relationship because so much attention has to go into getting the job done, getting the symptom addressed, getting the necessary medication, and sometimes we lose the personal part of it and how to talk. So therapy works with that as well. All right, medication, same story. If your person had a prior episode of depression, you don't want to give them the same medicine. If that's not within just a couple of months, you don't ever want to give them medicine somebody else in your family is taking for depression, and you don't want to assume they need medicine. You want to go to the doctor with your list, and you want to try to work with somebody who's familiar with prescribing for an older adult. According to the CDC, 80 to 90% of cases of depression in older adults are treatable at the same rate as adults of younger ages, making it one of the most treatable conditions. It's also treatable in the context of dementia. So you're older, has dementia, and then begins to show signs of depression. We don't say that must just be what dementia looks like, and it's terribly sad to have it, we say, let's have an evaluation formally, and we can reduce the symptoms of dementia, of depression in a person with dementia. It's important that we weed it out as much as we can, and we do the right thing for the right condition. All right, how do you start a conversation? Maybe you're really lucky. Probably all of you come from a family where you could talk about anything all the time with no problem. Talk about your feelings, talk about your worry, right? That's right. And then maybe some of you come from a place where we did not talk about hard things. We do not disrespect our elders by pointing out something that might seem like a weakness or a vulnerability. And the point is, it doesn't matter where you started, it matters where you are today. Your experience as a caregiver will be enhanced, your stress will be reduced if you do what I call dialing directly. Say to your person, be straightforward, but be kind. Don't diagnose yourself. You say, I've been noticing you don't seem like yourself lately. I don't know what's going on, but something's shifted. I'm concerned. You're staying in bed a lot, or you haven't eaten very well, or just care so much. Let's figure it out. Or you say, I've been worried. Can we talk about what you're experiencing? And ask. If they are not forthcoming, ask, am I the person you're most comfortable talking about this with? And if I'm not, let's find who that is. Sometimes it's a different family member. Sometimes older adults tell me, this person who's providing care for me every single day, I can't now have a conversation saying how horrible I feel inside. They have enough. I'm a burden. But I'll talk to my sister, or I'll talk to the other kid who isn't the one that's here every single day, or I don't want to tell my spouse. You're an older adult. In theory, maybe you're married to an older adult. Your spouse is going through adjustments to medical illnesses or other things, other functions of aging potentially, and you don't want to say, I'm really anxious. You want to just try to seem normal. Anxiety is almost contagious sometimes. If you're around somebody with anxiety long enough, you will either wonder what the statute of limitations is on certain behaviors, or you will notice all of a sudden that you are having some symptoms of anxiety, or you'll just want to get away from the person, which if you're providing care is not always an option. It seems like you're going through a difficult time. How can I help you to find help? You normalize this. You say, do you know what? Being a human is not easy. There are challenges. It doesn't matter what age you are. And I think that what is happening with you is not your fault, but I think you could feel a whole lot better. Let's go make somebody earn their money. Let's talk to somebody and see. Maybe they'll say, oh, it's totally normal. Maybe they won't. Join with them. At any age. At any age. I have a patient who's 97 years old. I love her so much. I want her to live forever. Any age can make changes in their mental health and well-being. And I have watched people do remarkable things. I have a 90-year-old woman who bought a computer exclusively to do sessions. I practice virtually exclusively now, and that allows me to see people all over the country and all over the state. And if my older has had cataract surgery or doesn't have their caregiver available to drive them, they don't miss a therapy appointment or an evaluation. So she gets a computer. I talk her grandchild through what she's going to need to do, and she says to me the first session, I can see you. And I say, I can see you too, isn't it great? And she says, yes, it's really great. And she says, how does my hair look? And I said, oh, it looks great, you look fantastic. And she says, good. So we go through our first session, she's just fascinated. The second session, she says, I don't know if you know this, but you can see your grandchildren on this thing. I said, no. She said, yes. And she said, you know, Louise next door, who's always hauling herself over here to tell me something, I can do this with her, and when I'm done, I just close it. And I say, do you say goodbye to Louise first? And she says, not always. I said, okay. So things can change. Please challenge the ideas you have about older adults can't do technology. They don't know it like a grandchild knows it, right? If I need something fixed, I'm going to hand it to a kid. They can learn, and they want to learn, and they need to be connected, and they need social support, and they need engagement. So caregivers, you have to be practicing your best self-care. I will say one of the things I didn't say about treatment for both of these, but more often with depression, if I always make sure that a primary care physician has cleared a person physically, but I ask all of my older adults to do daily exercise and to prove to me that they did. So some people take a walk and do their walk with me. And I know that in August, the leaves are not changing. So that was your walk from last October. But I knew that yesterday it rained, so I better see some raindrops. And sometimes people do a log, and sometimes people take a picture of a sign-in sheet for a chair yoga class they've gone. I want people to move ideally 30 minutes a day. Research tells us that 30 minutes a day of exercise reduces the symptoms of anxiety and depression by up to 50%. That is free in most cases, right? If you don't need the supervision of a cardiac rehab program, if you can take a walk, if you can sit in a chair and watch a YouTube video, that's free mental health care. I also personally ask my people to do something contemplative, whether that's prayer or meditation or journaling or reading material that's significant to them. And I ask them to also log for me their social interactions. Who did you talk to today? You don't have to tell me what you talked about. Who did you meet today? Who did you think of today? I have one woman who does a greeting card ministry, and I say, how many cards did you send out today? She'll say 20, and I got 5 phone calls from the ones I sent last week. So it's one of the ways she stays connected with people. All right, a key element for success: do not ignore changes. When you see changes, don't assume. Maybe they're nothing. Maybe they're situational. The reason that the diagnostic criteria includes the symptoms lasting for 6 months or longer is that major life events cause what we diagnose as an adjustment disorder. My spouse has died. I am not driving anymore. I have moved out of my beloved home. Those things cause people to have both anxiety and depression. That's normal, situational, circumstantial. We want to address that with people, offer strategies for self-care, but we want to make sure that we pay attention how long it's lasting so we don't avoid it. When you help your loved one, your life gets easier. It can feel so overwhelming to deal with anything, but particularly mental health disorders. There is still a stigma. It's getting better, but there is still a this on top of everything. Anxiety and depression are not normal consequences of growing older, right? Aging has its challenges, but we can reduce people's distress in the process if we give them some help with these issues. So, this is me. These are, I'm going to put them up for a second for you, my references for this talk, if that's important to you. They may put this talk up on a website so you would have access. If you're taking furious notes, you'd have access to these slides. You can't reproduce them, but you're welcome to learn from them if you want to, or know the criteria. And that's that, and I'm happy to talk to you about questions you have, or thoughts, or reflections. Did anybody learn anything they didn't know before this morning? Yes. Oh, good. Yay. What? What's something you did not know about depression or anxiety in an older adult before you met Dr. Vanessa Schaeffer?